Hello, everyone, and welcome to part one of Introduction to Pre-Oxygenation in the Pre-Hospital setting. My name is Austin Kaiser. I'm a flight paramedic and the clinical educator with PHI Air Medical in California. Some of the things we're going to be looking at today, we're going to understand and take a look at the current state of peri-intubation hypoxia in the pre-hospital setting. We're also going to review some best practice techniques for pre-oxygenating our patients. And in parts 2 and 3, we're going to look more at reviewing hypotension and working through the difficult airway successfully in our patients. So our first call that we have is a 59-year-old male, came into the emergency department with probable pneumonia, was doing pretty well on a cannula, but we came into the room and found him unresponsive, cyanotic, and having agonal respirations. So what do we see happening for this patient? And what I think that most of us have traditionally seen was maybe somebody runs into the room and they lay the bed or the head of the bed down flat and they start forcefully bagging him to try to improve his oxygen saturations and his skin signs. A couple nurses run into the room and start additional IVs, maybe draw some more blood. Physician runs into the room wanting an emergent intubation, not really caring about the current state of the vital signs, just needing to get that tube to hopefully save this person's life. And we do finally pass the tube, but we notice that the patient is now in a cardiac arrest. And we have this situation right here where we have to do compressions for 2 or 3 minutes, and then we get the patient back to life. And we kind of all walk out of the room feeling like heroes, feeling like we had just saved somebody's life. And what I would pose to you is, did we? Did we save that person's life? Does that situation seem familiar to you? And I think that for most of us it probably does. And if you think that, or if you do think that the death was unpreventable and that the person was just sick and that we did in fact save them, then I think that there's a few things that we could definitely look at in this presentation that would hopefully shed some light on a few things where we maybe did go wrong there. And so when I'm thinking about the fact that all peri-intubation cardiac arrests are preventable, then somewhere we had to go wrong during the course of that patient's care, and where did we go wrong? And I think that getting additional IVs is fine, and intubating is fine, but where we really went wrong was that we started to view the intubation procedure as the life-saving procedure and not the ventilation procedure. Intubation is sexy, but it is not life-saving. If ventilation is good, there is no emergency, and we are performing all life-saving maneuvers doing what is pictured here. So BLS, bag valve mask ventilation with a 2-person technique, this is where lives are saved, not with intubation. So why did our patient go into a cardiac arrest? Well, this patient that we're talking about specifically, the 59-year-old male, obviously had quite a fair amount of hypoxemia, probably had some hypotension as well, and we're going to talk about how to mitigate those two things or improve those two vital signs to prevent that cardiac arrest from happening in the first place. And there's actually 3 main reasons why somebody could go into a cardiac arrest during the peri-intubation phase. We've covered 2 so far, one being a hemodynamics issue like a blood pressure in the 80s, one being an oxygenation issue like oxygen saturation in the 70s, and then the other one is actually a pH problem, so your acidemia, so your crashing DKA patient who we don't properly compensate for as far as their relative respiratory alkalosis that they've got going on. We need to make sure and keep that up, and if we don't, then we're going to worsen their acidosis. So those are the 3 main reasons that somebody can go into a cardiac arrest during the peri-intubation phase. We're going to cover these top two, hypoxemia and hypotension, during the course of this three-part series, and then we're really going to look at the acidemia problem during part 3 of the introduction to mechanical ventilation when we start looking at ABGs. So intubation's pretty old. I mean, we've been doing it as paramedics since the dawn of our time, and physicians have obviously been doing it even longer than that. Unfortunately, though, we were taught by people who don't have to deal with the same types of patients necessarily, or the same dynamic environments that we do. And so when we learned how to intubate people, we learned it in a kind of expedient way. We learned it in a way that made it seem like we had to get the tube really quickly as soon as we decided to actually do the procedure, and that's just simply not true. So it's not really our fault that we seem to have a lot of peri-intubation hypoxia in the field today, because that's how we learned it, and that's how our instructors learned it, and it's been just kind of the dogma of EMS, much like backboarding, right? Just been kind of a dogma of EMS forever, but hopefully we can start to change that. So let's look at a few studies. The first is a pretty impressive study that Walker White and several others did with physio control in 2018, and they looked at EMS RSI intubations and found that of the monitor data that they pulled, 43% of EMS RSIs resulted in a hypoxic event, and almost 70% of those hypoxic events were severe, with saturations at or below 80%, and a quarter of those intubations, a quarter of those hypoxic events had saturations at or below 36% during the peri-intubation phase. So, I mean, essentially a mortal oxygen saturation, and the average length of time of that hypoxia was 2 minutes. I would also like to note that 70% of the hypoxic events occurred during the first pass, during the first attempt at intubation. So really focusing on just getting it on the first pass and not properly preoxygenating your patient beforehand probably isn't the best way to go. So is this just bad paramedicine? I think I probably answered that a few slides ago. No, it is not bad paramedicine. That's how we learned it, and that's how our instructors learned it. So it's just kind of a continuing cycle, and it's up to us to break that cycle. But it's not bad paramedicine if you were taught to do something. And it's not really exclusive to the field either. There was another study that was done and published in the Annals of Emergency Medicine a few years ago, and looked at emergency department RSIs and found that about a third of emergency department RSIs resulted in a hypoxic event during the peri-intubation phase. So really pretty close to what we see out in the field. One big data point that I would like to point out is that 93% of those hypoxic events occurred in patients who did not have hypoxia prior to the intubation procedure. So we caused that hypoxic event due to improper preoxygenation and pre-intubation management. So that's really, think about that, that we're increasing mortality and morbidity for these people just out of a rush and a complacency. Does it really matter, though? 2 minutes is a pretty short amount of time, really, when you think about the course of somebody's care, and I am here to tell you that yes, absolutely, it does matter. With a traumatic brain injury, so this data is comprised of several different studies that were done over the past several years. They're in the source notes at the end of the presentation. But in a traumatic brain injury, if you have one single episode of hypoxia, your patient's mortality rate increases by almost 300%. If you have one episode of hypotension, your mortality increases by almost 350%. And if both are present at any one point during the patient's care, it increases their mortality by 1,200%. So yes, any amount of hypoxia, any amount of hypotension with systolic blood pressure less than 90 matters in our patients, and we need to prevent that from happening. So in order to move to this new era of what we hope to accomplish with pre-intubation management, we really need to look at where we came from and how we are currently doing things. So how did we learn to bag via bag valve mask ventilation? And I think that 10 out of 10 people would say the C&E grip, right? So you grab that C&E grip with your probably your dominant hand, so you can try to do a good jaw thrust, and then you grab the bag valve mask with your non-dominant hand and you start squeezing on the bag. We use that because we were taught how to use bag valve masks back in the 60s from anesthesiologists who do it by themselves, but there's really no reason that we should be doing it by ourselves. And really, when you look at the data, bag valve mask ventilation is absolutely a two-person job, and that's why we're going to be talking about the 2 thumbs down, 2 rescuer technique for bag valve mask ventilation. So if you're using a single rescuer, a single provider doing the C&E grip and just trying to do a head tilt chin lift, we can see in figure A right there the the glottic view with a person doing the head tilt chin lift using a C&E grip. And on the right side in figure B, you can see the same exact patient, the same glottic view using a jaw thrust instead. So you're placing your thumbs down on their cheeks and you are lifting the angle of their mandible up toward the ceiling. So you're physically raising their mandible, doing that jaw thrust, using 2 hands down on the mask and getting a really good seal. You're physically lifting all of those structures off of the back of the airway, and you very clearly have a much better glottic view. It's going to be super easy to breathe for that person or to bag that person. You're going to have much less resistance and much increased compliance with that person's upper airway. Same thing in this picture. You can see on the top left there the glottic view with the head tilt chin lift, pretty floppy epiglottis right there. And then you look at the same view with the jaw thrust, and that epiglottis is way up and out of there, and you really get a great glottic view. And you can obviously easily have a much easier and much better pathway to get air into that person's lungs. On the right side of the screen, just to reiterate what those each look like, we have the C&E grip on top. So you've got that C on the mask with an E grabbing the mandible, doing a head tilt chin lift. And then on the bottom, you've got 2 thumbs down on the mask and you are physically lifting the mandible up toward the ceiling. That person's also doing a jaw thrust at the same time. So why do we do this? Why are we even focusing on this at all? And it's specifically to address and to stay out of the airway death spiral, which is a term that was coined by Dr. Ruben Strayer. The airway death spiral is something that happens when you have somebody who is either pretty good or thinks they're pretty good at intubation, but they are very poor at ventilation. That's how you get into the airway death spiral. So you have a person, you have a paramedic or a nurse who comes on scene, and they have a patient that needs to be intubated, maybe a trauma patient, and they very quickly tell some firefighters to start bagging them up, quote unquote, in order to prep for the intubation. You get all your stuff ready, you get your blade and an 8.0 tube, and you don't get any backups. You don't really have a plan for the airway because you don't need to, because you're super good at intubation. So then you pull those firefighters off, you get that bag valve mask pulled away from them, and all of a sudden you go in there with your blade and all you see is blood and secretions and some little bubbles. You realize that, oh my gosh, I have a ton of secretions in the airway and I can't see anything. So you tell your partner to go run and grab some suction. and your partner comes back with suction. You guys are able to get the airway suctioned, but you didn't really have a plan for the airway. You didn't really evaluate your patient very well because you were so confident in your skill that you didn't notice that this patient's only about 5'3" and 250 pounds. So they've got a really anterior airway. You hadn't really planned for that, not using a rigid stylet, so the bougie is just not quite making that angle, and you are unable to get it in the trachea, and you accidentally intubate the esophagus. And as soon as you pull that bougie out through that intubated esophagus, a bunch of gastric secretion or gastric secretions and blood start coming out of the tube. So you pull the tube and you're getting ready to start bagging your patient up, but you realize you haven't had your head or you haven't pointed your eyes toward the cardiac monitor in like 3 to 4 minutes, and the patient is in cardiac arrest. That is the airway death spiral, and it happens because we did very poor pre-intubation management, did absolutely no pre-oxygenation, and then we had no plan for the airway when we got in there. We didn't have any backup tubes, we didn't have any backup intubating adjuncts, we didn't have a backup plan for what happens if we can't get them intubated. We need to address all of those things before we ever lead with suction into that airway. So just to really recap on it, if the patient has a ventilatory or a respiratory emergency, we fix it with good ventilation. Once that happens, the emergency is over. Intubation is sexy, but it's not a life-saving procedure. So what are the 3 things that we need to do in order to properly manage this patient in the pre-intubation phase? We need to either normalize or compensate for the patient's inherent end-tidal CO2. We need to increase their oxygenation, and we need to reduce their alveolar nitrogen concentration. So blow off some CO2 if you need to, especially if they're in a ventilatory emergency, increase their PaO2, and denitrogenate their alveoli. So now let's look at patient number 2. We have a 19-year-old male with a polypharm overdose, pretty lethargic and obtunded, very bradypnic when they came in, not managing their secretions very well, and so the decision was made to intubate. Now let's talk about how to do it like a professional. So in order to intubate, or in order to pre-oxygenate like a professional, let's kind of look at some of the numbers that we're playing with here. And the first thing that we look at is this chart. This is called Benyamov's chart, and it looks at oxygen saturation over a period of minutes, so while the patient is apneic. So the y-axis has our oxygen saturation on it, and our x-axis is a measure of minutes, and this was from minute 0 to minute 10 after a patient was given 1 milligram per kilogram of succinylcholine and remained apneic. So we look over on the far right, that normal 70 kilo adult. So that patient was properly oxygenated, properly denitrogenated, and we see that after they were given succinylcholine, it took 8 minutes of apnea. 8 minutes of apnea in order for that patient to see an oxygen saturation of 90%. 8 minutes of apnea. That is a crazy long time. We don't really work in that patient demographic. We work really more toward the next one to the left, which is the moderately ill 70 kilo adult, and we see that that patient was never actually able to attain a 100% oxygen saturation. They were only to get them able to get them up to about 94 or 95%. But they properly denitrogenated those patients, and they properly pre-oxygenated those patients. And even though they've got maybe a little alveolar shunt or maybe a little hemodynamic issues, and we're not able to attain an oxygen saturation of 100%, it still took 5 minutes of apnea to drop their oxygen saturation down to 90%. The worst possible demographic is the morbidly obese patient, that 127 kilo adult, and it looks like it took still about 2 minutes and 40 seconds for their oxygen saturation to drop to 90% after being apneic. These are pretty incredible numbers, and ones that I feel like I never really appreciated in real life when I was working on the ground before I started doing this type of stuff, when I was kind of doing the old school hyperventilate, preoxygenation, and quickly intubate somebody. I would say anecdotally I had about T minus 30 seconds of apnea time before that patient's oxygen saturation was going to start to precipitously drop. And so we have to look at how we can replicate what they did. And what they did was they increased the PaO2 by increasing FiO2, and they also made sure that they had a huge amount of FiO2 available in the alveoli to compete with those large nitrogen molecules and start to wash those out of the alveoli. So we have alveolar denitrogenation as well. So back to patient number 2. We know that in order to attain this goal, we essentially have to, hyperoxygenate their alveoli in their blood for several minutes. And so we could start off by putting that spontaneously breathing patient on a non-rebreather at 15 liters per minute. And I remember from EMT class back in the day that for every 1 liter per minute you increase the FiO2 by approximately 4% over room air. So at 15 liters per minute, we should be giving a pretty substantial FiO2 to this patient, anywhere from 70 to 85 or 90% FiO2, depending on how much leak you have around the face mask there. But they're not receiving 100% FiO2, and in reality, they're not receiving 70 to 80% FiO2 either. And that's because a true non-rebreather doesn't exist in the wild anymore. You can see pictured here that the one-way valve that is over those 2 vents, that there aren't 2 of them, there's only 1 of them. And that's how all non-rebreathers come nowadays, because historically in pre-hospital medicine, we have a very restricted amount of oxygen in our tanks, and if you put a patient on a non-rebreather with 2 one-way valves over those vents, and you walk away from them and your tank goes dry, they're going to be rebreathing all of their CO2 until they become unresponsive. So the manufacturers got smart, and they just took one of their one-way valves off of those vents, so that if we do run out of oxygen, the patient can just breathe room air through that vent and not continuously rebreathe all of their CO2. So 60% FiO2 is okay, but it's definitely not ideal. It's not what we want. We want as close to 100% as we can possibly get in order to give our patients the best chance of denitrogenating their alveoli. And so the solution is that we're going to place an additional nasal cannula underneath at 15 liters per minute. And remember that this is a normal nasal cannula. This is not an end-tidal CO2 cannula. End-tidal CO2 cannulas, the nasal prongs are actually the end-tidal CO2 samplers, and then the oxygen is delivered through these little perforate holes up on that nasal bridge, and it does not deliver oxygen in the same way that a regular nasal cannula does. So this has to be a regular nasal cannula at 15 liters per minute, as well as a non-rebreather at 15 liters per minute. Now we're delivering 30 liters per minute flow, 30 liters per minute of flow. That is a ton of flow, and we really are nearing 100% FiO2 in this patient. So as long as they're spontaneously breathing, they should reach 100% oxygen saturation very quickly, and within about 3 minutes from the time that they reach 100% saturation, 3 minutes later, they should be fully denitrogenated. So that is not 3 minutes of 30 liters per minute. That is, we place the patient on a cannula and a non-rebreather at 30 liters per minute, and as soon as their oxygen saturation improves up to 100%, or as high as the oxygen saturation is going to go, we now start a 3-minute timer, and then we will reach full denitrogenation. Unfortunately, the textbook patient that we have on the left, which is the one we've been talking about, we don't intubate those people very often. And so the people that we do intubate is this gentleman here on the right, the older, sicker patient. And he's probably not taking good enough spontaneous breaths in order to reach that 100% saturation because he's just not moving any volume. So now we're looking at this 78-year-old male with diagnosis of pneumonia, really dyspneic, placed on a nasal cannula at 4, and his oxygen saturations were about 78%. Placed him on a non-rebreather and a nasal cannula, each at 15 liters per minute, and his saturations improved to a whopping 82%. And you should be thinking, how is this even possible, right? I mean, if you really think about the lungs, if you're delivering 100% FiO2 to the lungs and you're not saturating well, something else has to be going on that is affecting that, because as long as you're perfusing your alveoli, you should be able to exchange those gases no problem, and your oxygen saturation should be 100%. But that's just it, is that your alveoli have to be perfused, right? So a pretty good rule of thumb is that if your FiO2 is greater than 50% and the patient is not saturating well, then one of two things has to be going on. I mentioned one here on this slide, but really it's one of two things. The first is that you have a severely shocked patient who has very poor hemodynamics, and they are not perfusing their lungs very well. And you'll have a perfusion mismatch, and an oxygen saturation will go down. Or alveolar shunt has to be present. And for most of our patients, that is the most likely scenario, that alveolar shunt has to be present. Let's talk about what that is. So what is it? Well, it's if you can see in Figure A here, it is pretty obvious that it doesn't matter how much flow you put into these little terminal bronchi here, because none of those alveoli are open. We have severe atelectasis. In many of our patients, it might be fluid, it might be pus from some sort of infectious process, but it doesn't matter how much oxygen gets into the lungs. If it can't get to the alveoli, it can't get into the blood, and we are going to see poor oxygen saturation. If we look at this diagram here, you can see that on the top we have a well-ventilated alveoli, and on the bottom we have a very poor ventilated alveoli. So if we follow this from the left to the right, we have about a 50% oxygen saturation coming in from the pulmonary artery on the right side of the heart, and we're traveling up toward that well-ventilated alveolar unit. We are getting rid of a bunch of CO2, we are picking up a lot of oxygen, and then as it comes out the other side, it is fully saturated with oxygen at 100%. But unfortunately, that is only that alveolar unit. On the other side of the lung here, or right next to it, we have this 50% saturated blood coming in from the pulmonary artery and heading down to that poorly ventilated alveolar unit. No oxygen is getting into that alveoli, so obviously the blood is not picking up any new oxygen or getting rid of any of its carbon dioxide. So we have this CO2 level that is climbing, and we have this oxygen level that is declining. And so we exit that side of the lung unit at 50% saturation, when that really well oxygenated blood at 100% and that poorly oxygenated blood at 50% mix together in the pulmonary veins and enter the left side of the heart to go out to the body. We read a finger pulse ox of 75%. So that is alveolar shunt. So what's the solution? We need to add some pressure. We need to add pressure behind the flow. So simply, we need to keep some pressure in the lungs between their breaths. Remember that oxygenation does not occur very much during an actual inhalation period. Oxygenation really occurs underneath the curve. So in that space between breaths, and while we're exhaling, it's all the volume that's left in our lungs at any given time. that is oxygenation. So how do we improve that? Well, we need to keep a little pressure in the lungs in order to attain our goal. So when we think of leaving pressure in the lungs after exhalation, we think of PEEP, right? Positive index expiratory pressure. And so if you look at figure A again, you have this very atelectatic lung unit. You've got a bunch of oxygen coming into the lungs, but alveoli are not being perfused. But now we give them a little bit of PEEP, and all of a sudden we're seeing figures B or C, and all of those alveoli pop open and they stay recruited, and we have greatly improved oxygenation. So you can increase the flow or increase your FiO2 all you want, but if you have an atelectatic lung or you have alveolar shunt going on, then you need to add pressure in order to solve your problems. You need to add PEEP in there in order to solve your problems. So I've had people ask me, well, then why can't we just continue to do what we're doing and use a bag valve mask? Because a bag valve mask has a substantial amount of flow, 25 plus liters per minute, and you're putting a lot of pressure behind it. And this is why. So the top graph right here is what a normal bag valve mask pressure waveform looks like. So you give a big breath and you've got this huge initial spike in pressure up to like 30 centimeters of water pressure, which is not great. And then as your alveoli start to become recruited, you get this, this little plateauing of the pressure, and it might go down to, 20 or 22 centimeters of water pressure. But then as soon as you release your hand off of that bag and you allow that patient to exhale, it immediately goes down to zero, and all of those alveoli snap back shut, and you essentially are having zero oxygenation between those breaths during that period of apnea, that 2 to 3 second period before you give them the next breath. There's no oxygenation occurring whatsoever. Whereas if you put a PEEP valve on your bag valve mask and you dial it up to 5 or 8 or 10 or 15 or whatever you're going to do, now all of a sudden you have a ton of space underneath this curve, right? Underneath this waveform, because everything from the blue waveform down to the red line you should think of as oxygenation. And so you can see that there's a lot more oxygenation happening on the bottom than there is on the top after we've added in that PEEP. Also notice that if we leave a little bit of PEEP inside of the lungs, we leave all those little alveoli partially open, or partially inflated rather, we don't see those high pressures anymore, because the hardest part about blowing up a balloon is initiating it, right? As soon as we've put a little bit of pressure in that balloon, we've blown that balloon up just a little bit, now all of a sudden it's very easy to blow up. But if we let it completely deflate each time, then it's going to be more and more difficult to inflate that balloon. So let's look at what PEEP does on a cadaver here. So this is no PEEP. And now we just add a little bit of PEEP. And within 2 to 3 breaths, you see full lung expansion, full recruitment, and that is continuous oxygenation. So with PEEP, we have alveoli opening more effectively. We have more alveoli opening. We have no atelectasis between breaths, which means we have reduced atelect trauma. We have more time for oxygen to diffuse across the alveolar capillary membrane. And we have a much increased surface area of those alveoli, as well as thinning out of the membrane. So we have an increase in diffusion of all of those gases. So takeaways: bagging quicker and harder with a bag valve mask does not increase oxygenation. The only thing that increases oxygenation is increased flow and increased PEEP. All right, guys, thanks for listening in for part 1 here. Again, my name is Austin Kaiser. If you need to leave any comments or have any questions about this presentation, please feel free to reach out to me at akaiser@phirmedical.com. And we will see you guys again for part 2 of this introduction to preoxygenation.